Welcome back. I am excited about this panel because this is something that resuscitationists love to debate. Do you use lactated ringers? Do you use normal saline? Does it matter? This is what this great fluid debate is all about. So we have Dan Patino and Eddy Gutierrez who are going to be squaring off, talking about whether or not lactated ringers or normal saline is the best fluid for resuscitation. Same rules for the debate still apply. 7 minutes for each point, and then 2 minutes to come back and counterpunch your opponent. We decide that Eddy is going to go first. So Eddy, when you're ready, you get 7 minutes to state your case. Let's go.
So I have to tip my hat to Dan because he's very courageous to go up against me to have this discussion of balanced salt solutions, and particularly LR as the title of this debate stands. You know, if saline was created today in its current form and presented in front of the FDA, honestly, it would not be accepted. The reason why is because, it's not physiological as much as we might like to call it normal saline. But the reason why I say this is just look at the composition. Pick up the bag of saline and read it for yourself. If you look on it, it has a pH of 5.0 versus LR has a pH of 6.5. Now, for amateurs, it might be nice to just say, oh, it's acidic because it has a pH of 5.0. But the thing is that we need to think a little bit more in a more sophisticated manner and recognize something called the strong ion difference. The strong ion difference is the difference between cations and anions in a solution. This includes our blood. So when you look at 154 milliequivalents of sodium and 154 milliequivalents of chloride, that gives you a strong ion difference of 0. LR, on the other hand, has a strong ion difference of 24, and our plasma, depending on what you read, has a strong ion difference in the very low 40s. Plasma light, as a little bonus, has a strong ion difference also that's in the 40s. But that being said, you create more of a metabolic acidosis because of the strong ion difference in patients who receive abundant amounts of saline. Then looking at the composition even further, you have 154 milliequivalents per liter in normal saline versus 130 in LR. And none of the trials have really looked at the hypernatremia component of this, but it's something to recognize because those of us who have had patients resuscitated with a lot of saline, well, what happens after is you have to de-resuscitate them. When you diurese them, you end up giving them Lasix. And what happens is that they excrete a lot of free water and very little sodium. So they become more hypernatremic. Then they become delirious, they have ileus, constipation, all those things that complicate the length of stay of the patient. So it's not benign. LR has a sodium of 130, and I'm going to give it to Dan because there are some caveats to recognize about this sodium of 130. With regards to the chloride load, that's what causes the metabolic acidosis in these patients, that hyperchloremia, because that chloride actually constricts the afferent arterioles in the glomeruli. This causes AKI, decreased GFR in patients, and that is seen in some of the clinical trials that I'm going to discuss soon. Then you do have that potassium of 4 in LR. And people often think that this is going to cause hyperkalemia in the patients, but this is not accurate. In renal transplant studies, they have shown that the serum potassium is actually higher in the patients who get saline versus those who get LR. The reason for this is because we have to remember that in acidosis, the potassium shifts from the intracellular space to the extracellular space. So with this hyperchloremic metabolic acidosis, patients are shown to have higher serum potassiums than in those who receive LR. There is some calcium in LR, which has its caveats that you have to recognize. But in addition to that, LR has the elephant in the room, the lactate. And we are fascinated with this lactate-guided resuscitation, which has its caveats. But we have to remember that this is sodium lactate, NLR, and not lactic acid. And always remember that the brain, as well as the heart, love lactate for fuel. But let's look at the clinical trials. My opponent might bring up the split trial where they randomized patients to get saline versus plasma light, and they showed no difference. But remember that this was a pilot study. They only got about 2 liters of fluid, and they weren't that sick. Then more recently in Vanderbilt, they had the Salty ED trial, which was a big trial with over, I think it was like 16,000 patients or something like that. And they had a composite outcome of some sort of kidney injury. I can't remember it off the top of my head. But that was basically death, renal replacement therapy, and creatinine bump by greater than 200% or something like that. And they had a number needed to treat of greater than 110, which isn't a good number needed to treat. But nonetheless, think of how many patients in the emergency departments where this trial took place. Think of how many get saline versus LR. We could actually save some kidneys. The ICU side of this trial, the SMART trial, did show also less composite outcome of kidney adverse events, which had this criteria that I can't remember off the top of my head, but the number needed to treat here was 94 or somewhere in the 90s. So you do see some benefit with these particular patients. But they did a subgroup analysis of this SMART trial, and they found that using balanced salt solutions versus saline in patients who are in septic shock and who are critically ill from that, the number needed to treat dropped into the 20s. So you do see a good benefit in these patients by giving balanced salt solutions over saline. Then more recently, the BASICS trial, when you look at it just right off the bat, you say, hey, there's no difference. But when you really look at the patients who received balanced salt solutions from the beginning of resuscitation all the way to the end, there was a significant mortality benefit in these patients. So it's not that saline is going to be the best solution, because it honestly isn't. Balanced salt solutions are the way to go. And you could also take it out and put it in the subgroup of patients who have DKA. There have been a couple studies published recently looking at balanced salt solutions versus saline in DKA, and they have found a couple key benefits here. Number one, that the DKA resolves faster. You don't have a hyperchloremic metabolic acidosis contributing to the patient's underlying acidosis from the DKA. So acidosis gets better, they get better faster. Then in addition to that, these patients come off the insulin drip faster. That also leads, conversely, to a shorter length of stay in the ICU, because we're all cramped for beds. We're all trying to turn over patients as soon as possible. If an intervention as simple as IV fluids could cause you to have a shorter length of stay and get better faster, I don't even see how this is a debate. This is pretty clear cut, and I sympathize for my opponent, Dan, because balanced salt solutions, including LR, are definitely better than using saline for resuscitation.
Eddy coming in hot. Dan, I hope you have something good for Eddy, because you can't let him come at you like that. Dan, 7 minutes, state your case.
All right. So Haney, when you first asked me to do this debate, I was really excited to be part of it, because I love talking about fluid resuscitation. It's one of my favorite topics to discuss with my residents. But I was a little bit concerned about how we were going to make this work, because back in my shop, I'm known as a lactated ringers guy. I use LR for most of my resuscitations of patients who are critically ill. It's my fluid of choice, and it's continue being my fluid of choice until the evidence tells me otherwise. But at the same time, I know that Eddy has done such a great job with promoting the use of balanced fluids. He's a lover of LR. So I was a little bit torn about which side I was going to take. Now, obviously, I'm going to agree with most of the things that Eddy has said so far. I think lactated ringers is a great choice in certain clinical scenarios. It's a more physiologic fluid. But I am going to disagree on two particular things. So first, I'm going to disagree that lactated ringers is, although it's a great fluid, it's not the best choice of fluids for every clinical scenario. And there are two specific scenarios where I personally think that normal saline is a superior fluid. The first one is in patients with traumatic brain injuries. So patients with TBIs may have an intracranial bleed, and as a result, their intracranial pressures may be elevated, and they're at higher risk for developing cerebral edema. They can develop herniation, and as a result, giving a hypotonic fluid like lactated ringers doesn't make sense from a physiologic standpoint. So LR has a serum osmolality of about 273, which is slightly hypotonic compared to what we have in our serum, which is about 275, 280. Now, on the other hand, normal saline has a slightly hypertonic concentration with a osmolality of about 308. So when we're taking care of these patients with intracranial bleed, high intracranial pressures, one of the first things that we do if a patient starts to decompensate, in addition to reversing anticoagulation or taking care of their airway, is to give them a hypertonic fluid like 3% saline. So in a patient who requires fluid resuscitation and has this clinical picture of increased intracranial pressure, my fluid of choice is going to be normal saline. Because lactated ringers is slightly hypotonic, it can potentially increase the risk for cerebral swelling. Now, we have evidence to support this. So the BASICS trial, which was published in 2021, looked at over 10,000 patients who were critically ill, who were admitted to ICUs in Brazil. And they compared the use of saline with a balanced crystalloid. And they did a subgroup analysis that looked at patients with TBI. And what they found was that patients who received normal saline had a statistically significant lower mortality rate than those patients that received a balanced crystalloid, such as Plasmolite or LR. Now, the other thing about the BASICS trial is that it also showed no difference in 90-day mortality when comparing normal saline and a balanced fluid. So again, there is some evidence to suggest or to support that maybe the choice of fluid doesn't really matter most of the time. Now, the second situation where I would consider fluid resuscitating with normal saline as opposed to lactated ringers are in patients who have a profound acute metabolic alkalosis. So 3 prototypical scenarios where I think about this. So these are patients who have a bicarbonate excess either due to large volume emesis where they're losing a lot of hydrochloric acid, or in patients who have a contraction alkalosis from overdiuresis. These patients will typically be hypochloremic, hypokalemic, and they'll have an alkalosis. And then the third and less common would be in patients with large alkaline ingestions. So the reason why normal saline is a better fluid in this situation is because of some of the things that Eddy has mentioned so far. So normal saline has a large chloride load, which can potentially be beneficial in these patients with alkalosis as they tend to be hypochloremic. The other nice thing about saline in this situation is that, as Eddy said, saline in large volumes can develop or can contribute to the development of a hyperchloremic metabolic acidosis. So if your patient is already profoundly alkalotic, let's say with a pH of 7.6, they have bicarbonate levels in the 40s or 50s, giving this acidotic fluid that can potentially cause a metabolic acidosis might be beneficial, as it will bring down the pH to essentially a normal level. Now, the one caveat here is that you do not want to treat a patient who has a chronic metabolic alkalosis, such as those patients who have COPD and are trying to compensate. This should be left alone. However, in those patients who have an acute metabolic alkalosis, from what we talked about, vomiting or contraction alkalosis or alkaline ingestions, saline may actually normalize their pH and bring it back to a normal level. So again, I'm gonna say that LR most of the time is going to be a great choice, but it's not always the right choice. And in certain clinical scenarios, such as the 2 that I discussed, normal saline is a superior fluid.
You know, Eddy, Dan's a pretty smart guy, so I'm going to give you 2 minutes to come back at him and make your case.
First of all, Dan is 100% correct. He makes some fantastic points about patients with traumatic brain injuries, that, these patients, we do need to protect that brain. That's very important. But one of the things that we have to be academically honest, and I'm not trying to side with Dan on this, but we went into these large randomized controlled trials regarding saline versus balanced salt solutions, expecting a fantastic mortality benefit. And I can't believe I'm saying this right now, because I'm going to shoot myself in the foot with the argument I'm going to make. So I guess I'm flipping this debate on its head. But if you're really academically honest with yourself, you have to kind of stretch a bit to see the benefit of using the balanced salt solutions over saline. And the reason why this is important comes down to cost. We can't put the way we practice in the United States, where we have all these resources, and use the same information throughout the rest of the world. A lot of places, unfortunately, cannot afford the additional 40 cents a liter that, for example, LR costs, or the additional $1 in most institutions that plasma-like costs compared to what saline costs. So when you consider the fact that today we're using a lot less fluids because we're using more fluid responsiveness measures to give patients fluids, we're not giving those 9 to 10 liters that Manny Rivers gave in 2001. Now we're giving about 3 to 4 liters. And at the end of the day, are 3 to 4 liters of saline really causing that much harm? Well, we're not seeing that in the basics trial nor the plus trial. So you should give LR, but if the only thing you have in your back pocket to give your patients is saline, it might not be that bad after all.
All right, Dan, Eddy's not letting up. You get the final say, the final 2 minutes of this debate. Let's go.
So I think Eddy just agreed with me. So I think that means I won the debate. Is that correct? Yeah. so honestly, I think this debate that we're having about whether LR or normal saline is a better choice of fluid. We're going to have this debate for the rest of our careers. I don't think we're ever going to have definitive evidence to say one is better than the other. So typically what I do in my practice is I focus on physiology, right? So if physiologically it makes sense to give a hypertonic, hypernatremic, hyperchloremic fluid like saline, then I'm going to do that, right? So it's not very common, but there are situations where that might make sense. On the other hand, lactated ringers might be a better option in other situations like DKA or profound sepsis. And I think we need to take into account each patient's clinical status, their underlying metabolic issues, their underlying physiological issues when deciding what fluid we're going to choose. Fluid, like any other intervention in medicine, has the potential to cause side effects. It can, cause a lot of issues. So we have to be very careful, not only in the amount of volume that we give, but also in the choice of fluids. Hopefully down the road, we'll have more studies that kind of look at this and gives us more clear-cut answers. But right now, my practice and what I teach to my residents is focus on the physiology, focus on the underlying metabolic derangements, and that's how you should choose your IV fluids.
All right, folks, there you have it. The LR debate, the normal saline debate. Now it's time for you to chat it up in the chat and let us know what you think, what you're going to do on your next patient that needs resuscitation. And then we'll come back to some of your comments a little later in the conference.